So today, the aging cancer patient population in North Carolina with Hyman Muss, MD, and we're thrilled to have him here. He's a difficult guy to get on. It's difficult to get on his schedule, so we are so happy to have him here. Dr. Muss, welcome.
Thank you very much. It's a pleasure to be here.
Let's see. Well, you're an experienced clinician scientist and the Mary Jones Hudson Distinguished Professor of Geriatric Oncology at the University of North Carolina School of Medicine and Director of Geriatric Oncology. Whoops, I'm jumping slides there. Sorry about that. Doesn't want to stay on that slide, but we'll get it there. There we go. Director of Geriatric Oncology at program at the UNC Lineberger Comprehensive Cancer Program. Interests in education and research focused on cancer in older patients, and you're an internationally recognized leader in this area. Particular interest and research expertise in the care of breast cancer patients with a focus on the management of older women. You also have a major interest in breast cancer survivorship and long-term toxicity of treatment. Dr. Muss, and we've got a lot more information on here, but in the interest of time, what's one other thing maybe outside of your professional bio that we should know about you?
So I'm a loving grandparent of 3 grandchildren. I waited a long time. For those on this webinar who don't have any yet or who want them, it may take a long time, but they're worth it. I'm married to a wonderful woman, Loretta Muss, who was very active at UNC. She's a retired nurse who's come back in to do patient-centered care and actually is delivering lunches to the nurses today. They try to do that to thank the real heroes that are seeing all our patients. And I know this is true for everybody on the call in healthcare. I'm a Vietnam vet. Today is Veterans Day. My daughter called me. That's another story for another time, but I'm proud to have served. We have a great country, and no matter where you come from and looking at the politics, this is a great place, and I'm very fortunate to be here, and I appreciate you inviting me, Tim.
Dr. Muss, thank you, and a big thank you to you and all veterans. Happy Veterans Day, and please, we are honored by your service. Please know. Let's take a look at this poll. The aging cancer patients have different concerns than do younger patients. Now, I will say, as most of you know, our first question is a softball. This is no exception here. A, true, B, false. While you're taking a look at that, I will say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME, and Hyman Muss, MD, has no financial relationships with commercial interests as defined by the ACCME. Phew, made it. Okay. So let's take a look at that poll, and that's open. Should be able to respond to that, and Dr. Muss will give them just
Sure.
maybe another 15 seconds or so to respond. And already we're seeing a pretty significant trend. And again, aging cancer patients have different concerns than do young cancer patients. If you think that's true, A, and if you're using the text, that would be A there. If you think that's false, B. All right, Dr. Muss, how are they doing?
I think they're doing pretty well. We'll cover it. They do have different concerns. Some of the concerns are similar, so I can see why some of the people felt that they were similar, but in general, there are differences, and we will cover that.
Great. Thank you so much. Well, let me go ahead and move on to the slide, the aging cancer patient population in North Carolina, UNC Cancer Network, November 11th, 2020. I'll turn it over to you.
Okay, next, please. Okay, so I think the objectives were on the invites, and I won't belabor them, but we'll talk a little bit about demographics of aging and cancer. I'm going to talk a little bit about a geriatric assessment, which I hope some of you will be interested in doing after this talk, and then how we go about thinking of getting a treatment plan for older cancer patients. And I should say, I see some of the people on the call here, some of the centers have worked with us And I may have some data to show you later about your own center. Next, please. So we're going to cover these areas, and we will cover goals of therapy. And I'll show you some tools that are available to all of you for looking at benefits of treatment. I'm going to use breast cancer as an example, but there are tools for all different types of cancer. And I'll show you more of a generic tool for chemotherapy toxicity. Next, please. Okay. So the U.S. is aging and certainly becoming more diverse. I think we're all aware of this, and North Carolina is no different. Cancer is a disease of aging, and the strongest predictor for the incidence of cancer is age. And as we get older, we're more likely to get cancer. In older patients, cancer can be an annoyance, and you might say, well, what does he mean by that? But a very tiny little breast cancer that's a few millimeters in someone with a lot of other comorbidities may be more of an annoyance than a life-threatening problem, or it can be devastating. Pancreatic cancer, any metastatic cancer, acute leukemias. One problem we have is older patients have been consistently and remain underrepresented in clinical trials. I'm old enough to know when I started practice, they were frequently excluded from trials. And now, although no trials have upper age limits, frequently we vote with our feet and we don't actually offer trial participation to older people. So that's become problematic because our treatment decisions are frequently based on clinical trials with much younger patients. We also have a shortage of geriatricians. So if you have a sick older person and want to co-manage them, it's sometimes hard to find a geriatrician. This is a problem. People are working on this nationally, and we desperately need more geriatricians in this country to work with all types of specialists, not just cancer, to improve care of older people. Like caring for older patients, it's a team game. All of medicine is now a team game. And certainly, as we'll go through in this lecture, there's no place that teams are more important than caring for an older patient. Next.
So here we have our next question. The average of a new cancer diagnosis in the United States is about, and if you think that's 35 years, A, 45 years, B, 55 years, C, 65 years, D, 75 years, E. So thanks. Some of you already jumped right on that. We appreciate that. We'll take another 10 or so seconds to give you a chance to fill these out. And by the way, there's no grading here today. These are all anonymous. So just take your best guess on this. All right, Dr. Muss, we seem to be settling around 65 with the most votes, but also kind of an equal number for 35, 45, and 55. How are they doing?
Well, they're doing well. The average age is actually 66. And
okay.
I will say a lot of participants had younger age, and I think that has to do with how cancer is marketed in the United States among the media and other things. It's not really probably great for your product to put a 75-year-old person with cancer, as the marketing person. So frequently when we have a big telethon, Stand Up to Cancer, you see all these elegant younger men and women. You think of Brian's song, whereas actually the average age of cancers in this country getting a diagnosis is 66. So I think we did well, and this is an important point to know because our population is aging and we're all going to be seeing these patients.
All right. Thank you, and thanks so much to everyone for answering. And we'll go ahead and there you go.
Okay, so this is what the incidence curves look like cancer in the general population. And if you can look at these green bars, you can see, and the incidence is the number of new diagnoses per 100,000. So you can see it really gets much higher in older age. Now, if you look in the average population of people who actually are living with a diagnosis, it's a little younger because there are more people in their 50s and 60s in the population than in their 70s and 80s. But fortunately, with healthcare improvements, we're getting many, many people living into 80s, 90s. I have a few patients 100 years old now. I never had that 20, 30 years ago. So we're all going to be seeing more of these people. Next slide, please. This is what kind of North Carolina looks like in its growth of older adult populations. And if you can see, our state is growing as well. This is our own North Carolina facts and figures. You can see we're growing in suburban and urban areas, but virtually in all areas, we are having a lot of growth of 65 and older patients. These are just general population, not cancer patients. And it supports our concerns of caring for older people. Next. And we're also changing our demographics. So this shows what's happening in our state now. And about 38% of North Carolinians now are Black, Hispanic, Asian, other ethnic groups. And we can see the growth of this state is really focused on these patients. So we not only have an older group, but we're getting many different cultures, racial groups, ethnic groups involved in our growth of the state and in our aging of the state. And a lot of these groups have different views on cancer, different experiences with cancer, and this is something we need to keep in mind. Next, please. So why are we so concerned with older people? So this is a breast cancer study that was done looking at the cause of death in women with early breast cancer. And these are the U.S. cancer death rates over time. This is breast cancer mortality. And you can see there's been marked improvements in mortality over the last really 20 to 30 years. And if you look at the blue line on the bottom, you can see marked improvement in the youngest patients, 20 to 49. But where I put the red arrow is the older patients, 75 plus. And the point here is that the older patients really have done better, but they haven't shared as much in the improvements and outcomes as the younger patients. And one of the problems related to this is undertreatment. A lot of people see an older person, 70s, feel he or she doesn't want optimal treatment, they've led the good life, et cetera, and they end up getting lowballed. So it's something concerned. This is breast cancer, but there's similar data from many of the other common cancers. Next slide, please. So how do we manage an older patient with breast cancer? Well, we're going to talk about performing a brief geriatric assessment. This is something all of you can do, and I know some people who are participating have already done this and are really good at it, probably better than I am. And then I'm going to show you some tools to estimate life expectancy, because when you see an older patient, the question really isn't the patient's age, but their life expectancy. And then we're going to talk about defining goals of treatment. And lastly, what can we do to calculate some of the risks and benefits of treatment? I'm going to use a breast cancer patient as an example for this, but the principles apply to all cancer patients. Next, please. So here are two women. On the left is Katharine Graham. So in her 70s, she was running a big newspaper and publishing empire, was really an incredible woman, doing lots of things, running big businesses, et cetera. And on the right is a patient exactly the same age. And if you saw both of these patients, your brain would immediately think differently about them. But they're both the same age. So it's just an extreme example of using age to make decisions is not a great idea. Next. Next. So it's really life expectancy. And this is a large study, 250,000 Medicare patients in this slide. And I circled the 80 and older, and you can see the blue line are people who have no comorbidity. So they're 80 and they don't have any bad lung disease or heart disease or other cancers. And you can see they have an average survival of 12 years. So if they have a terrible cancer, acute leukemia, and you've to estimate their life expectancy, That's a lot better than you may have thought. And you might want to reconsider what treatment options you give these older patients. And I picked 80 because that's usually an age where we all, when we hear it, feel, oh, that's a really older person. Next. Now I'm going to use Sarah Jones, this is not a real patient, as an example of caring for an older patient with cancer. Next. And here she is. She's 77. She states she's in very good health, and she has a body mass index of 29. And it's very important in older people to look at the BMI, because if it's low, they may not be eating well. And it's usually not cancer. It's that older people frequently don't have the joy of eating, company, don't prepare meals, etc. So low BMI is a bad thing in older people. This is okay. She has high blood pressure, hyperlipidemia, and hypothyroidism. She drives. She has no functional deficits. And ADL is activities of daily living. These are people who you got to be able to dress yourself, bathe yourself, feed yourself, etc. Basic things. If you can't do this, you've got to be in assisted living or nursing care facility. IADL, instrumental activities of daily living, are things that you need if you want to live independently in the community. Shopping, using the telephone, paying your bills, etc. So she can do all of that. She hasn't fallen. She previously smoked. She's never had cancer. She has an 82-year-old husband with mild dementia, and she is the major caregiver. And she now feels a breast lump. And we'll get into the breast lump issues in a while, but I want you to look at her general health status. Next. So the question here, is cancer her major illness? She now has a breast cancer diagnosis. Is that her major illness? Next. And you want to know, what would her life expectancy be without cancer? Without cancer. That's why I showed you all of her other medical and social issues. Next. So this is just a repeat of what I've showed you. Next. And the question is, what do you think her chance is of surviving 10 years? And I think that may have been lost off my next slide, but Tim, this was fine on this slide. So what do you think her chances are of living 10 years? I didn't mean to usurp your turf, Tim. I'm sorry about that.
No, Dr. Muss, please. That's just fine. Oh, wow. And this is great. We've got a great audience, lots in attendance today, and thank you for jumping on that question. Dr. Muss, so just a reminder for those texting, A, 5 to 10%, B, 15 to 20, C, 25 to 30, D, 40 to 50, and E, 60 to 70. And while we wait for a few more results, I'll also remind our audience that we will have an opportunity for you to share your questions with Dr. Muss at the end. So you might want to be jotting those down. Dr. Muss, how did they do?
Well, they did okay. And I think going to the next slide will be helpful. So I urge everybody to learn how to use this program called ePrognosis. It's free, it's on the web, and what I love about it is you don't need to spend 15 minutes registering, getting a 16-letter password. You can just go in and use it as a healthcare professional. And what it does is it has data from community living adults in this country that accurately can predict actually 10-year mortality, median survival. So I put Sarah Jones in here, and you'll notice on the right, what goes into this program is age, smoking history, BMI, whether she has any other serious illness. And I noticed prior cancer, no. I want to know, and you want to know, what is her life expectancy without cancer? When you ask her, how do you rate your health, Sarah? She says, very good. That's very important. That's an important question. And even if she was in terrible health, if she said very good and a woman in similar health said very bad, the woman who says very good will live longer. And then she's not dependent on anybody for any of her daily life activities. And there's a question here about walking a quarter of a mile, etc. And she's very good at doing that. Next. So these are questions that you can't always get out of the medical record. You got to ask the patient. But they only take really a few minutes. And next, her 10-year mortality risk is about 20%. And the answers given by this group are similar to, would be to 50 experienced physicians would have given a lesser, a higher mortality risk in this patient. And this is why it's so important to use these tools, which are validated in thousands of Americans in this study. So this is very helpful and something that you should calculate and is important to get in the record when you're making a treatment decision. Next. Now the geriatric oncology iceberg looks like this. Next. On the top of the iceberg is the usual things we find out about cancer patients. What's their age? We use something called performance status that many of you are familiar with, which is a very crude way of knowing, are they ambulatory? Do they have any symptoms? We get their tumor characteristics, and then we do labs and we examine them and get an idea about organ function. But next, these are all the things in older patients that frequently we don't assess well that can be critically important. Polypharmacy, taking too many drugs. Falls. About 40,000 Americans die of fall-related injuries each year. That's as many as women who die of breast cancer. So finding an older person with falls, just as you're taking care of them and maybe sending them for physical therapy for balance training, can be as effective sometimes as a cancer treatments. Psychosocial issues, very important, discovering anxiety and depression in older people. Functional decline. If they're doing poorly, maybe PT and OT can help them. Cognitive impairment is tough, but it's important to know about it because you need to make sure the patient can understand the issues related to their treatment, and if not, get suitable surrogates from the family to help. Nutritional deficits, we talked a little bit about earlier, loss of muscle mass, and social support. Social support is so important for older people. If you take two older people with the same cancer diagnosis, same stage, and one has a great social support, friends, kids that take the patient out, and another lives in one of these areas for older people in a small apartment, never with any visitors, the mortality rate is much higher for the people without social support. And you can do something about it. So if you find out they don't have it, you can find out maybe there's an aging center close by that has activities for older people. Maybe you can call the family and say someone needs to take mom out once a week for dinner, whatever, but you can approach this. Next. So we use the brief geriatric assessment at UNC, and many on this calls are familiar with this. This is actually a Lineberger Registry Protocol 0916, and includes a health professional assessment, which is just really a few minutes. It's an up and go test. You get in a chair, you see the patient get out of the chair, walk out 10 feet and come back. It's a poor way, like a 6-minute walk, gait speed, etc. They're all the same, and it's directly related to survival. We do performance status, and then you must do a little mini mental status exam. Older people frequently look at doctors and nurses as professionals, and they're not clients, they're patients. They have a different cultural view of many of their healthcare providers, and they'll frequently dress up for the visit and look great and not know what they ate for lunch. So you need to have an idea of their memory, their cognitive status, and a little screen, takes a few minutes, can help. Self-reported, and that takes 5 to 10 minutes. The self-reported aspects are things you can do with this assessment, and I'll show you the website at the end of the talk, but you can assess activities of daily living, falls, you can look at comorbidities, you can look at little screens for depression and anxiety, you can assess social activity, and a question or two on weight loss in the last 6 months. So next, it doesn't take a lot of professional time. And in fact, I wrote health professional, but this can be done by probably any office staff you have. And next, the self-reported. Takes about 10 to 30 minutes. Some patients will just go through this quickly. They don't have any issues. Some people you will have to help get through this. It's tablet-based, and we can get these results to you virtually immediately. Next, please. So issues, though, it takes a little time. There's a lot of assessments that you can download on the web. I think they all kind of measure the same thing. And I like this CARG assessment. It's simple. It's free. You don't need to spend a lot of time getting into it to use it. You will find problems you don't routinely discuss, like social support or falls. And it's important to know these because many have beneficial interventions. So it's not just trying to find problems that you can't do anything about anyway. You can use some of the data, as I showed you, for the e-prognosis, and I'm going to show you it can predict cancer-related toxicity. Next. Now, if you don't have time, you can use screening tools. This is the G8 screening tool. It's 8 questions, and it's pretty good, actually, and it's something you can do very quickly. And I put Sarah Jones in this, and she really comes out well. Next. Here, her score is 15. Any score above 14 is good. It's a very tight screen. So if there's a problem, and then you could do the geriatric assessment. But if you're busy and don't have the time, you can at least do this one. And this is very, very helpful. Next. So now we've done our assessment. We've estimated her life expectancy. And now what are the goals of treatment? Next.
All right, and this brings us to our next question. Which of the following is the major concern of older adults recommended for chemotherapy? A, hair loss, B, cost of treatment, C, loss of function, or D, parking at UNC? And again, which of the following is the major concern of older adults recommended for chemotherapy? And I'm guessing that there may be some folks who haven't parked here who are missing
Yeah, I'm
D.
glad to see it. That may be the right answer.
Oh my gosh. All right, Dr. Muss, how are they doing?
Well, they're doing well. Cost is always an issue, but I must say Medicare is very generous in helping people, but that really doesn't, a lot of older people, just costs associated with getting to the clinic and getting families is major, but really it, as we'll show, it's loss of function. So this is really good. Next slide, please. So what are the goals of treatment next? So I can never resist showing this slide because this is really it for all of us. I suspect if we're healthy, we all want to get to 100. Next, please. So when we discuss goals, you need to be aligned with the patient. In younger people with cancers, any type of cancers, they're frequently most interested in what are their chances for cure, if anything, or if it's all going to be palliative care, whether it's chemotherapy or other treatments. They want to have some idea of how long they're going to survive with their cancer. Now, older people have similar interests, but when asked in surveys, the main thing they will tell you is the treatment for my cancer going to make me a burden to my family? And that's a key thing. You may have a person who's living out in the community, but if they had any major issue like a fall or a fracture or neuropathy from their cancer treatment, might be forced to be in assisted living or another place. So it's very important when thinking your treatment to think about these issues and to go over it with the patient. Because a lot of oncologists are looking, what's the progression-free survival and the survival rate, and that may not be as important to the older patient. We all, for cancers of any age, want to minimize the symptoms and focus on quality of life. But quality of life issues, and quality of life issues differ for different people, what they are. You really need to ask people if they say, I'm interested in quality of life, what that means to them. For some, it could be related to longevity. It's others to minimize treatment toxicity. Very important to really get the patient's input. And our goals may be a little bit differently, as noted below. Next, please. So Sarah Jones, she has a breast mass. We've shown she's got a really good 10-year mortality rate. She's likely to be, 80% of people like her are likely to survive. So she gets a lumpectomy and axillary dissection, and it's a big breast cancer. It has numerous positive lymph nodes. It's hormone receptor positive. Because of the size and number of nodes, she gets CAT scan, bone scan, and it all looks fine. So we've got this big breast cancer on her. Next. So how do we determine the benefits and risks of treating her? Next. Well, we know her life expectancy, and at least for breast cancer, and there are similar models for colon cancer, other tumors, this model predict plus 2 can be just, if you put this in Google, you will come up with a little calculator, and it gives good estimates of adjuvant therapy. So in this patient, we would think of giving her endocrine therapy. We would think of giving her possibly chemotherapy, and the purpose of this therapy is all to improve her chances of cure. So this program will allow us to calculate overall survival of patients like this at 5, 10, and 15 years. There's some validation in women in their 80s. She's not, but that's very important. And these data are based on people of average health in the United Kingdom, probably similar for the United States. And there are certain other things you can do, but you can also print it out for patients. And they have these little stick figures, which are very popular, and sometimes that helps explain things to people. Next. And so we put her in the model, and we see that if she were doing well with cancer, at least living in the UK, with no cancer, this is average health. 63% of people would live 10 years. So how come in the earlier question we got 20%? Well, that's because e-prognosis really factors out who's in really good health or average health. If she just had her surgery and said, I've had enough, I'm going home, about 40% would be alive at 10 years. So that would, so that's a substantial drop. If we put her on tamoxifen or other pills that usually are tolerable in older people, we can save 7 lives out of 110 years. So that's something we would usually do. But when we get to chemotherapy, you can see the number of lives saved, even in this older woman with positive lymph nodes, gets to be small, 3 and 5 lives, depending on the intensity of the chemotherapy. Next. So it translates into this that 24% of people like this, if you did nothing, will die of breast cancer. You know, you may be shocked. More people are going to die of non-breast cancer causes at this age. Endocrine therapy will save 10 lives, and chemotherapy will save a few more lives. So this is a breast cancer patient. Next. And in selecting therapy, next, we like the PREDICT model because it gives accurate estimates. And if we lived in the United Kingdom, which has a really well-defined healthcare system, next, this is how they would make the decision for chemotherapy. And this is something they do nationally. So if the chemotherapy would improve the survival of a patient like this only by a few percent, and this to me would be true for colon cancer or what's the chances of curing the leukemia, then they wouldn't recommend chemotherapy because they feel these estimates are within the realm of error of the model. If it was 3 to 5%, they discuss the side effects of chemotherapy in detail with the patient, the potential benefits, and go with the patient, make a mutual decision, make a mutual care decision. And if it was greater than 5%, they would recommend considering chemotherapy. So this is their national standards. There's obviously a little play in this. Some people will pick a very small benefit and tolerate any toxicity, although not usually older people. And some people will have a dramatic benefit of 10% and say, Doc, I don't want any treatment. So there's always a personal decision involved. Next. Okay. So How about toxicity? So this is a patient who said the following. Next. She told us that if your time hasn't come yet, not even a doctor can kill you. So this was a sweet woman. Unfortunately, not quite correct in what she said. Chemotherapy can be really overwhelming. We usually don't take people's lives with it, but it can make people very sick and on rare occasion be life-threatening. Next. So how can we calculate the chemotherapy toxicity for Sarah Jones? So there's actually, if you go into that CARG website, which I'm going to show you at the end, there are calculators for calculating the risk of severe chemotherapy toxicity. And this model is for all types of cancer, both early and curable cancer and advanced cancers. And this was a study done by the late Arthur Huria, a wonderful woman, geriatric oncologist who died in her 40s in an accident, tragically, who taught us so much. She was wonderful and did these models to help with patient treatment. So you can see on the top, going into this model, we have a lot of things you know about the patient, which would be things in general care of the patient, including her age, the type of cancer, whether you're going to give her a standard treatment or you think she's a little frail, I'll reduce the dose. And you have these. And then what I've circled are things that you got out of your geriatric assessment, like falls, hearing assessment, limited in walking, assistance with meds. Now, there were tons of questions asked here in the geriatric assessment, but these were the questions that worked out in the model. So if we put our Sarah Jones in, she's greater than 73. In breast cancer, we usually treat all the chemotherapy regimens. Modern ones usually have more than one drug, and which we call polychemotherapy. And we're thinking she's pretty good. We're going to give her a standard dose. And then she does have decreased social activity because she's taking care of that husband of hers and can't go out and maybe do a lot of things that she would like to do with her friends, go to church, perhaps, what things she likes to do. So next. So if you look, she's got 9 points. And what does that mean? Next. It means that if you look at the score, she has a 50% probability in panel A of having grade 3 to 5 toxicity. Now, those are bad toxicities, like bad diarrhea, nausea, vomiting, stomatitis, neuropathy. Some of it isn't bad, like a low white blood cell count, may not be dangerous for a few days, but it's a good way to look at the major toxicity. Now, for those not familiar, grade 5 toxicity is not surviving chemotherapy. It's a chemotherapy-related death. And fortunately, in this model, that's a rare event, just a percentage point of 2. And a lot of these patients did have metastatic cancer. Now, on the right, we have what all oncologists use, the performance status, and you could see it's virtually worthless in trying to calculate her risk of chemotherapy. Whether you're very great shape or not, on the eyeball look, it's not helpful. So this is a very, very helpful model. Next. And we've just got a paper which we hope will be accepted in the next week or so, looking at chemotherapy in women 65 and older just with breast cancer. And you're going to see this coming for other cancers as well. And in this model, we not only calculated the side effect risk, which is similar to what I showed you before, but we looked at things like dose reductions, dose delays, hospitalization, and RDI, relative dose intensity, because there are data that people who can't tolerate the standard doses of chemotherapy, who are less than 85% able to tolerate the planned dose, don't do as well. Their cancers are more likely to relapse. So we're going to have a lot in this model that you'll be able to calculate. And this should be up on, once the paper is accepted, available to everyone here to use in their care of patients. Next. Now, we also have looked at some clinical trials. This was a trial we did in the Alliance, one of the national cooperative groups. Some of you are members in the community in this trial system. it previously was called the CLGB. And this was a study we did for women who went on chemotherapy. They were all 65 and older, and we wanted to look at their functional decline. So this was seeing at the end of chemotherapy who wasn't as fit as when they started chemotherapy. And you can see there's a substantial number of patients who at the end of chemotherapy declined a bit, 40%. That's substantial. We weren't sophisticated enough to know what this meant as far as moving you out of your home into assisted living, but it was very worrisome. But was nice, we called it resilient. About half of those patients subsequently rebounded and got better by about a year after their chemotherapy was completed. But you can see another small percentage declined. And we're not certain in those patients whether they declined because of their treatment or because these are an older group of people, they just got other diseases. So it's somewhat reassuring. Now, this is a clinical trial. The people who went in it were older, but generally healthy. But it gives you some idea if a patient asks you about what's going to happen to me, am I going to be able to take care of myself, how they're likely to do. Next. Now, these are data that we've gotten at UNC from some of our trials. And this is a database of about 250 patients. All these patients had breast cancer and got modern adjuvant chemotherapy regimens. So these are patients, if you're familiar with the chemotherapy given today, were aggressively treated. Now, there's obviously a bias here because they were picked by their physicians and nurses as being resilient and strong, but I can tell you, most of them didn't have a geriatric assessment up front that the doctors used. And we looked at all the side effects. These are patient-reported outcomes. So this isn't what the doctor or nurse reported. This is what the patient reported, a patient-reported outcome. And you can see that for virtually this whole realm of side effects, it was pretty similar for the people above 65 and the people below 65. So this is pretty reassuring. It's not that that older person is going to get much more nausea or vomiting or fatigue compared to the younger person. Pretty reassuring to discuss with older patients. Next. And this is a slide I put in because, you know, one of the problems in modern medicine, I don't think I need to tell people on this call, is we're all being asked to do more with less. Whether you're a nurse or a research associate, we're getting numerous emails. I don't know how many of you are on the Epic system, and I can tell you I get numerous chats per day. And between that and my iPhone and all the sensory input we get, when are we going to get time or to do a geriatric assessment? So this is just to show you that you can, if you do a face-to-face physician, there's even a doing this, a non-physician can get reimbursed for this. Now, if you do this, I put the CPT code. This is very practical data. If you're out in another hospital and do this or you practice, you need to run it past your own practice manager. But I can tell you I've spent a lot of time on this at UNC, and we're very conservative in our billing system, very cautious. And you can see there's a reasonable amount of RVU about reimbursement for doing this. So if you can work this into your practice some way and do this face-to-face, you can get reimbursed for this substantially. And I'd urge you to think about it because I can't expect you, my colleagues, to do this in this medical environment with all the issues without some support. Next. These are key websites, and I've alluded to them throughout the talk, and I hope if anything, you'll copy this down. I used the Google because none of us can remember these URLs or put them in, but if you Google this, you'll get all these sites. The ePrognosis, calculate life expectancy, take you 10 minutes. MyCarg has the whole geriatric assessment and the toxicity calculators. There's also a wonderful toxicity calculator from Moffitt Cancer Center available on the web that's a little bit more chemotherapy specific and may be helpful. Predict UK is great for breast cancer. And if you're really interested in learning more about older people with cancer, the International Society of Geriatric Oncology, ASCO, is great. I use CancerNet, ASCO free for patients. It's really good. I don't know how many of you have medical records that require after visit summaries, but in mine, rather than the 50 million appointments they need to keep and everything, I actually put a list of some of these websites for them, so when they get home, they can use it. I cover vitamin D and follow-up, etc. Things that a lot of patients ask you, and CancerNet is really nice, has a really good section on geriatric oncology. For those of you who really want to get in the weeds on this, POGO-E is a great website which has video clips and all kinds of stuff about how to care for older people, not just with cancer, but anybody. And if you're asked to do a lecture, they have slides you can download and everything that may be very, very helpful. So this is, if you get a chance in your travels, this is a really nice website to look at. Next, please. These are all our cancer clinic sites involved in our geriatric assessment. So I know some of you are on the call, and we have had terrific participation. We are having, I should have told you, Tim, we have a geriatric oncology symposium on November 20th. It's going to be in the afternoon. It's a week. It's at UNC. You're all invited. You're all invited. Last year, we actually had a little workshop in the morning where many of people from outside hospitals came and shared their experience. And all of these sites have done the geriatric assessment. So they've all done it, and they're using it in their office, and it's really a terrific thing. Next.
Great. And Dr. Muss, with your permission, I will send something out to our audience about November 20th. Great.
Absolutely.
Thank you.
And if you're actually interested in the study, we're always like the Marines. We're looking for a few good men and women here to come into this. So keep it in mind. And these are what we've had in participation from outside sites. So I'm just showing you data from the community that many of you had generated. So this is looking at just the age distribution for the different sites. And next is looking at the different issues we had in the IADL score. So what were the things that people, these IADL scores tell us people who can't live in the community without help. So if you have an aging parent, you're going over to mom's house to check the electric bill, did she pay it, make sure there's enough food in the fridge, the usual stuff. This is IADLs for all the different sites. So it's rather substantial, and a lot of these you can kind of do things to make things better for your patients and even for your family. I know this is relevant to my family. I've been through aging parents now 4 times. Next. And these are social activities. So we asked about social activities, and you can see in the different sites, a lot of people were restricted in their social activities. So these are people, I live in Chatham County. There's a wonderful aging center in Chatham County near Pittsburgh. And a lot of people don't know about it. And they can pick people up and spend the day with other people, eat lunch. It's kind of a cool thing. So if you don't ask, you don't know. And these things are very beneficial to people and frequently supported with your tax money as well. Next. So in summary, older people and cancer, we want to base on life expectancy, our decisions, and I've shown you age is just poor in older people for life expectancy. Most 18-year-olds are going to be pretty healthy, although not all, but 75-year-olds are going to vary all across the spectrum. So use the screener, the geriatric assessment, to dig in a little bit. Once you've figured some of this out, go over the goals of treatment, look at benefits and risks of treatment. I've shown you some calculators for breast, but there are other available for other cancers. And as a good friend of mine told me, if you've cared for one older cancer patient, you've cared for one older cancer patient, because there's all issues with family support, social issues, education, etc. So every patient is an individual, and we always need to think of that. But in older people, there's a really great diversity. Next. So thank you. Again, thanks Tim and his crew for letting me do this. Thank you all for attending. Many of you are the heroes of COVID, taking care of other patients, so thank you for that. And I hope this was of some help to you.
All right, and Dr. Muss, we thank you, and with that, we'll go ahead and open this up to questions. And so just use Poll Everywhere to submit your questions to us, and we'll take as many as we have time for. While we're waiting for those to come in, let me ask one. So I'm imagining there may be situations where the priorities of the family and the priorities of the patient are not always exactly aligned, and maybe a daughter or a son is thinking,
Exactly.
I want mom or dad to live as long as possible, and the patient may have other priorities based on quality of life and the treatments that she or he may be facing. How do you help to
Great
the
question.
patient navigate that?
I remember as a young guy, I had a patient that needed radiation, and I talked with the patient before her family came in and about it, and she said, yes, I would like to have the radiation, but please don't tell my family. And then the family came in and said, don't tell mom she needs radiation. The way I handle this is I think cancer is like this is a family illness. And I bring everybody in the room face to face and eyeball, because the family needs to hear what mom wants. And frequently the people pushing hardest may not be the people caring for mom. They may be the son or daughter who comes and sees mom twice a year, while the son or daughter who lives next door and has watched mom decline for 6 months and knows what mom's wishes are is much more relevant. So I think you need to bring everybody face to face. And when someone says, I want everything done for my mother or father, you need to ask them, what do you mean by everything? Because frequently when you explain the issues of side effects of treatment, surgery, chemotherapy, radiation, people's mind change. They don't really get it, what they were asking. So you've got to prune down the question, but I think you get everybody in a room. Now, someone has dementia, it's a different thing. But most people don't. And even people with mild dementia can make good cognitive decisions. So get them in there. And when someone says, I want mom to have everything, you look at mom and say, I know you love your daughter. What do you think of this? And that's what I do. And it doesn't always make a lot of friends, but actually at the end of those meetings, people can be relieved.
I'll
Because if
bet.
they hear it from their love, from their mom or dad, it's much more crisp and come from me.
I'll bet. That makes sense. Thank you so much. So I'm just looking to see if we have, we have one that just came in. Let's see. Well, this is more of a comment, but we appreciate that. Thank you for this presentation and for your service. Happy Veterans Day to you.
Thank you.
All of us here certainly echo that.
Thank you. Thank you.
Let me see if we've got any others. We're just about at the hour, so what I'm going to do is advance a few slides, and then I'll come back to our questions and see if any more came in.
Sure.
I do want to thank the North Carolina taxpayers for all of their generous support in making this happen, and the General Assembly for their generous support of the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, and the team here, Mary King, Veneranda Obure, John Powell, and Anita Woodyard, for all the hard work they do for each and every one of these lectures.